Alright, so we're going to go ahead and get into just cardiac monitoring and ECG use. I trust that everybody in here is pretty proficient in putting on our 3 lead 1, lead 2, lead 3, your salt, your pepper, your ketchup, and your turnip greens or pickles or whatever you want to call it. Some people say, what do they say? They say grass under clouds, smoke over fire. Nonetheless, you should just be able to look at the lead and it say right arm, left arm, and all that. Anybody know where, how long ECG monitoring has been around? Been around a lot longer than 30 years. So actually, ECG monitoring has been around for over 100 years as we know it, as looking at waveforms, but a lot of the basic research behind the idea that we've got electrical impulses going through the heart date back even as far as 1790. Just a little history just to make it a little more interesting. In 1790, a guy named Luigi Galvinin realized, hey, there's some electrical impulses that go through the heart, that go through the muscles and all that. So he actually killed a frog, cut off his legs, hung his legs up, and took electrical stimulation and prodded the frog's legs and essentially made the frog's legs come back to life. In 1790, if you saw half of a frog and then all of a sudden its legs are moving, you would think, hey, somebody just brought that frog's legs back to life. What's that got to do with EKG monitoring? Well, just the fact that that's when the concept and the idea of the electrical system in the body, not just the heart but in the body, started coming around. They started thinking, hey, what's going on in the body? What's making things move? And they realized, hey, there might be some electrical impulses. And then, I'm sure there was some advancements between then and 1855, but in 1855, this is where our focus kind of turned towards the heart. A guy named Colliker and another guy named Mueller. You know, folks can't ever do anything just by themselves. It's always two guys, Franklin Starling, you know, Herring, Brewer, all that stuff. Anyways, these guys made the connection between the rhythmic pumping of the heart and the electrical phenomena of the heart. So they realized, hey, the heart's pumping in a rhythm. Something's making that rhythm be rhythmic, for lack of a better word. Something's making that heart pump in a rhythm. So they noticed that, hey, I bet you it's some type of electrical stimulus that's making this happen. And then in 1880, Ludwig and Waller realized that the heart's electrical stimuli could be monitored from the skin. How do you think they did that? They just kind of looked at it. They realized, hey, I can look at the heart, I can look in that area, and I can actually see that when a maximum impulse, where you can see the heart beating. And then came kind of the granddaddy, or the daddy of EKG. Who do you think that is? Y'all have heard this before in advanced ENT. He has a triangle named after him. Einthoven, Willem Einthoven. So he's the one that kind of put all this together. Initially, he placed 2 skin sensors, which were rudimentary electrodes on a man, then connected the ends to a silvered wire, which ran between the poles of a magnet. Every time the heart beat, the wires would twitch. Alright, so that would pick up the electrical stimulus. So then he said, well, how can I actually look at this? How can I look at this? How can I put it on something objective that I can see? So he projected a tiny light beam across the holes in the magnet's poles across the twitching silver line, and the twitching was recorded as waves, which he named what? What do you think he named the waves? PQRST, on a moving scroll of photographic paper. So somehow he placed those wires in between the 2 poles, all right? He placed wire between the 2 poles, and he shot a very minute amount of light in between the 2. And then each time the heart would twitch, each time that wire would twitch, it would actually record on photographic paper. Now, I don't know all about photographic paper and light and how it actually did it, but it would actually record. Very rudimentary, very basic leads. So then he realized that, hey, the leads, every time the heart twitches, it has a specific pattern. And then he named those waves in that specific pattern the PQRST. And then in 1901 is when the very first EKG machine evolved. Now we know it as ECG in modern times, but it was EKG. EKG, ECG is still the same thing. He just was a German guy, and I guess he liked to use a K in it. There is this book that I need to show you guys, and it's a very good book that if you could find it on Amazon for real cheap, I would recommend getting. That's where I get a lot of my information from, and I have to show you because I can't remember all the specifics right now. My mind's kind of going crazy. Anyway, so all that was kind of FYI, just to give you a little bit of a history. So the concept of electrical stimulus in the body and recording these waves, it dates way back, way back. Now originally the first EKG machine is nothing like the one that we know now. It was probably as big as both of these tables put together, and the guy actually had to put his foot in water to ground it out, and he had these two giant wires that were hooked up to it, and the EKG roll that it was recording on, I mean, was probably this big. So things have really changed since then, but that's where it all started from. So why is that important? Not a whole lot of importance to this class. It's just kind of interesting to know where we came from. I've said in my other class, you know, in order to know where you're going, you need to know where you came from. Just that simple. Why is ECG monitoring important for us? Well, the whole basis of EMS, the whole basis of paramedicine, was originally founded to improve cardiac arrest and to improve cardiac events in the pre-hospital setting. Back in the 1960s, when EMS started really evolving as what we know as modern-day EMS, they were trying to improve the outcome of pre-hospital cardiac events. So cardiac treatment, cardiac intervention, that's really the foundation for EMS. All right, talk to any paramedic, any competent paramedic that's that's working in the field now. They're going to have, if they don't have anything else, they're going to have a really good, firm foundation in cardiology. All right. It's very important to be very familiar with your machine. Now, everybody's seen the Zoll machines, right? Everybody's used the Zoll machines, but now that's not the only EKG machine out there. All right. I know that when I worked at AMR, we actually had the life packs. A lot of people use the life packs. So all the machines out there, it's going to be very important for you to understand how to use the one that's in your service. We have the Zolls here, so those are the ones that we're going to use and that we're going to practice on. And they're kind of the most common in this central area right here. Our cardiac monitoring is not going to be our just total definitive treatment tool, right? Because you're going to hear it said 1,000 times in this class and any other class, you treat what, not the what. You treat the patient, not the monitor. But it's still going to be a good diagnostic tool. So you've got your standard limb leads, and then we get into the other leads as well. But your standard limb leads are going to be your leads 1, 2, and 3. All right? They're called limb leads because the polarity, the poles, your positive and negative pole is formed off of your limbs. All right? Lead 2 is going to have a negative in your right arm and a positive in your left leg. All right? So they all attach to your limbs. One basic thing to remember in ECG monitoring is that your waveform or your ECG monitoring for a normal ECG monitor It's going to travel from a negative pole to a positive pole. All right? It's going to travel from negative to positive. When it starts traveling backwards, when it starts doing different things and traveling through its normal path, that's where you start looking at your arrhythmias on the monitor. That's where you see your arrhythmias. Then, yes?
Which lead is negative? Isn't it just one lead that's the ground?
Well, in any monitoring, you're only going to have two leads, all right? That's going to have to be the negative. So in like lead 2, your negative is going to be on your right arm, and your positive is going to be on your left leg. All right. Lead 3 is going to be left arm, left leg, and so forth. So they all form the Einthoven triangle. So the polarity of the lead will change depending on how you're wanting to read your monitor. So if y'all seen on the monitors, you can change your lead function. When you change your lead, what you're actually doing is changing the polarity of your leads and looking at it at a different angle. You're looking at the electrical stimulus that's going from here to here, then here to here, then here to here. All right, and then once you get in your 12 leads, it's all going to come back to the middle. Your 12 lead is going to be your best tool to provide detailed information about the heart's conduction system because it's going to give you the activity of the heart in 12 separate angles. Kind of gives you an electrical snapshot or electrical picture of the patient. The 12 lead as we know it, it's only really going to give you a good look on the anterior, inferior, and a little bit of the posterior and lateral walls of the heart. But then on the right side, you'll learn to actually change the leads over and do it that way. Now, just for all intents and purposes, we would just do a 12 lead on the left side, but we're going to get into right side monitoring as well. Now 12 lead, of course, it gets into more interpretation and all that, but again, we're going to treat our patient, not our monitor. All right? So our 12 lead can give us a diagnostic tool that, hey, we've got some type of MI going on or something like that, but again, we're going to treat the patient. Now what's important about a 12 lead is that it can get the information that you've got on your monitor to the hospital real quick. And I brought it up a couple of weeks ago, but anybody remember the old show Emergency with Johnny and Roy? Y'all see the big boxes that they're carrying? One of them's a radio and one of them's a monitor. And they've been transmitting EKGs since the 70s. We just now have really started in this area. Your electrode placement, easy. Everybody understand this. White, black, red, green. That's your standard electrode placement. Anybody not understand that? If they're real hairy, it ain't going to stick. Shave them. Alright? You may need to rub the site with alcohol to kind of get the sweat and all that off of it. Also, I know this may seem very elementary, but attach your leads to the actual wires before you put them on the patient. Because it gets very uncomfortable when we start trying to push those leads on somebody. Alright? Especially if they've got a little bit more body fat than other people, because you start having to push real hard. Then turn the monitor on. We're going to print a strip. Artifact. What's artifact? Yeah, artifact is going to be the monitor picking up on signals that aren't the electrical stimulus of the heart. It could be the patient moving. It could be 60 cycle interference, which is the radio and the electrical system of the ambulance. It could be potholes. It could be whatever. You've got to be proficient in determining what's artifact and what's not. Your baseline should always be flat. If it's wavy, then it's more than likely going to be artifact. If y'all got your y'all got your little handouts that I sent you. The skill drill 1, that's just going to be your basic monitor operations. It's 938 in the book. Now, I know, again, all this may seem simple, but those are things that we're going to have recorded that you checked off on, all right? So just know those skill drills and just know your basic, you know, it's as simple as just going up and hooking up the monitor, something you've been doing since EMT, okay? So your limb leads are leads 1, 2, 3, AVR, AVL, and AVF. Leads 1, 2, and 3 are the basic leads. AVR, AVL, and AVF are your augmented leads. Your augmented leads are leads that are going to look at the heart from a different angle, but the stimulus isn't going to be strong enough to actually be recorded on a EKG strip. So the monitor has to augment or electrify that signal or amplify that signal a little bit more. So that's why they're called augmented leads. So you know the basic lead placement. So I don't think I need to go over that. Now, your limb leads can actually be placed on the limbs, all right? They can actually be placed on the wrist and the ankles and still pick up a good signal, all right? For the convenience of riding in the ambulance and for the convenience of the patient, we usually just hook it up to their chest and all that, so it's kind of just hidden and out of the way. But they can be placed on the limbs. So your limb leads 1, 2, and 3, they form Einthoven's triangle. So what Einthoven's triangle is basically just the view that we're getting of the electrical signal of the heart. All right? So why do you think lead 2 is the best quickly to look at the normal electrical system of the heart? Look at the axis. Look at the angle. How does a normal electrical impulse go through the heart? Goes kind of that same angle, right? SA node, AV node to the ventricles. So that's why lead 2 is the best quick look lead. Now, if it sees something more, then we definitely don't need to rely on lead 2 only. Then we need to go to our 12 lead monitor. So your basic lead that you're going to use on the ambulance is lead 2. All right? Every monitor is already defaulted to lead 2. So the way it works is what I told you earlier. You've got your negative, your right arm in lead 2 is going to be negative. I told you that we're recording the impulse from what to what? From negative to positive. All right? So your positive is going to be your left leg limb lead. All right? So for lead 2, we're recording the EKG strip starting here and going down here. All right? So we're recording from the AV node going down. So your lead 3 is going to give you a little bit different angle. All right? So your lead 3 would be from the right shoulder to the left leg, so it's going to look more on this side. Is that making sense? And then your lead 1 is going to give you a little bit more of a different angle that's going to go more of the superior part of the heart. Not great diagnostic readings, but that's why if you watch a monitor, you may see a PQRST in lead 2, and it's got great amplitude. It looks like a real good rhythm. And if you look at it in lead 1 and lead 2, it's still going to read those, but it's picking that signal up from a different area of the heart, and so it's not as amplified. Does that make sense? Well, we're still looking at the basic electrical system. Right, it's just across that axis there. So it would actually read the SA node and all that, but it's actually going to pick up on some of the firing that's going across the top of the heart too. Your augmented leads, they're created using the 4-limb lead, so we don't have to put any extra leads on to get these readings. Leads AVR, AVL, AVF are created by combining 2 of the limb leads and using the other leads as the other poles. The example that we see is the lead AVR is created between the right arm and combination of the left arm and the leg electrodes, with a green lead serving as a ground. So what it does is these augmented leads actually combine 2 of the poles and make them both negative, and then it reads from both angles, okay? But because of the way that it's looking, the amplitude's not as great, and then it has to actually be amplified in the monitor. The monitor has to kick that waveform up just a little bit. Now, we really only look at AVL and AVF when we look at those. AVR, if you ask any doctor, and we get Dr. Sin to come in here and tell you guys, and talk to you guys about 12-lead stuff, he'll tell you AVR is kind of just there. It's just kind of that guy that just hangs out, but we don't really get any good diagnostic information off of AVR. The next are your precordial leads. How are your precordial leads formed? By using the 12-lead. Alright? So the 12-lead is not only going to include your 4 basic leads, but it's also going to include your precordial leads too. So V1, V2, V1, V2, V3, V4, V5, V6. Alright? And then when you actually get into reading 12 leads, it'll make sense as far as to where the placement is, as far as to where you're looking. So if you're looking at V6, then you're actually looking at the lateral part of the heart. Alright? That makes sense because it's on the lateral part of the heart. Okay? You follow me? So V1 and V2 is going to give you your septal view. Alright? Here's the heart right here. You just can't hardly see it. The V1 and V2 is going to give you the intraventricular septal view. Alright, so it's going to look at the electrical conduction of the septum. V3 and V4 is going to show you the anterior wall of the left ventricle. So that makes sense. See where it's at right there? So they're going to pick up on that right there. You follow me? Alright? And then V5 and V6 is going to look at the lateral wall of the left ventricle. Alright? So, why do you think that we're looking a lot at the left ventricle? Right, because if it's having conduction issues, if it's having problems getting cardiac output out, then the whole body's going to shut down, right? And then this is where I was talking about you can do right-sided ECGs where you just flip. This is used to evaluate the electrical activity of the right ventricle. And so the premise is the same except for having leads 3, 4, 5, and 6. 3, 4, 5, and 6 here. It's just going to have leads 3, 4, 5, and 6 on this side. Alright? Yes?
If somebody has the condition where their heart's on the right side, how would you place them in?
Well, first off, you would hook it up to your monitor normal and realize, hey, something's not right. And then you would flip-flop it. You would put these on that side, and that would give you a view of the left ventricle. And then you would just change your monitoring lead.
Reverse them all, include 1 and 2.
How do you switch V1 and V2 when you're looking at the right side?
Why do you use wide?
Instead of putting V1, V2, V3, it's the V2, V1, then 3, 4, 5, 6.
Well, it's not, well, I guess it is swapped if you're looking at it like that. Because they're still going to read the same area of that heart, and they're in a position where it doesn't matter if we change them or not right there, they can still read that same area of the heart. So, we're looking at the right part of the septum, right ventricular septum, so they both can still read that same part there. Does that make sense? Then posterior ECGs, these just go on across the back. Now, sometimes you may have 18 lead instead of a 12 lead, an 18 lead, and it just continues on towards the back. All right? Just know that this can happen, okay? Because hardly are you ever going to have time on the ambulance to flip somebody over and put a bunch of leads on their back and all that stuff, all right? So you hardly won't ever do that. That gets a lot more advanced than just learning how to read rhythms and stuff like we need to do in here. So this is what I was talking about, the 15 lead and then the 18 lead. So just read over that stuff. We won't even really get into that at all until we get to 12 lead stuff. And then I can almost bet you that if Dr. Sim, when he comes in, if he gets to do the 12 lead stuff, he'll probably say, worry about your 12 lead. Alright? Unipolar versus bipolar. Leads 1, 2, and 3 are bipolar leads. They contain the positive and negative poles. And what does leads 1, 2, and 3 form? Einthoven's triangle. Leads AVR, AVL, and AVF, they're your unipolar leads. And they have one true pole. The other end is referenced against a combination of other leads. So your augmented leads, they just combine a whole bunch of different leads to get these readings. It gets confusing. I know. Really know your bipolar leads, though. Your bipolar leads are what we're going to standardly use. Leads AVR, AVL, and AVF are augmented unipolar leads containing one true pole while the other end is referenced against a combination of other leads. An example would be lead AVR, the white electrode at the right arm referenced against a combination of the left arm and the left leg. Bipolar leads have a positive and negative end. Alright, so that's what forms Einthoven's triangle, right? We know that lead 2, this pole up here is going to be what? Up at the top. And this pole is going to be positive. That's why it's bipolar. It has two poles. It goes from its negative to its positive. Negative to positive. Negative to positive. Negative to positive. Alright? Pretty simple enough to understand, right? This is kind of a, and I've actually got a little bit better picture in the next presentation, but this is kind of a picture, if you could imagine, just imagine this as a camera. It's taking a picture of the electrical system of the heart this way. This way is taking a picture of the electrical heart system this way. Same thing here. It's taking a picture of the electrical system of the heart that way. Alright, so that's how the leads work. The leads work by taking a picture of the electrical stimulus that goes from the negative to the positive lead. Alright? The way that the augmented leads work is that they come together. See, you've got your AVR and your AVL. They're both positive. They come together right here at this little place called the Wilson's Terminal, and then they travel together to AVF. They travel to the positive. Alright? Now, with your 12 lead, your signal is going to come back to the center right here. And that makes sense because we're trying to take a picture. Let's just use V6. We're trying to take a picture of the lateral wall of the ventricle. So we need to look at it from outside to inside, right? We need to look at it from the outside to the main electrical stimulus, all right? So you're getting a view. Just imagine these are cameras taking a picture at each of these angles of the heart. And that's all it is that you're taking a picture of the angles of the heart. Now, they throw in 12 lead stuff in here right now. Now's not the time to worry about the 12 lead stuff, okay? Now's the time to understand basic monitor lead placement and to understand how the bipolar leads work, how we're going to read a rhythm, all right? It's just showing you these so that you have a little bit better understanding of the way it works there, all right? I think I've already said this. The bipolar leads have the negative and positive end. Lead 1, the left arm is the positive terminal. Alright? So we're going from the right arm to the left arm. Lead 2, the left leg is the positive terminal. And lead 3, the left leg is the positive terminal. Alright? What? Yeah. They got turned around. It should be right here. Alright? Anybody just so far confused right now? You are.
What's the difference in that and the in between study?
Nothing. It's the same. This is a crap picture right here. They should not have done this.
Right.
They should not have done this. This is a crap picture right here. Alright? Alright, so forget that picture. Forget that picture.
Okay, I'm back to normal.
Are y'all good now? Y'all good now? So, in Einthoven's triangle, that's what happens when you depend on torso. And he's got really long legs. That should be Einthoven's triangle.
So the signal always goes from negative to positive.
Signal will always go in your bipolar lead. Your signal will always go from negative to positive. What? If you look at the thing, did I write it backwards? No. Look on page 940. Einthoven's triangle.
No. I'm saying that you say has positive and negative. So you have negative,
Oh, yeah. There you go. All right. All right. I'm about to go off on some heads. But take that picture from that we just saw where for whatever reason they decided to put it on the right leg and just throw it out the window. That's Einthoven's triangle. So when we're looking at leads 1, 2, and 3, we're looking from the area of negative to positive. Okay? Alright. ECG concepts. You should know how this basic stuff works. Alright? We've already talked about it. Your P wave, your QRS, and your T wave. Every time a waveform happens, it should return to baseline. Alright? Y'all listen up, listen up. It should always return to baseline. So your baseline is also called your isoelectric line. Your isoelectric line is the part of the reading when the heart does not have any charge at all. Okay? A positive deflection is going to go upright. A negative deflection is going to go down. So when we're reading it, when the heart fires, if we're looking at lead 2, so we're that's not a good heart. When we're looking at lead 2, whenever it fires, initially is traveling towards the positive. So when the atria contracts, it's going to show a positive deflection. Does that make sense? Because when the atria contracts, the electrical conduction is going towards the positive, right? It starts at the SA node and goes down. Alright? When it gets to the AV node, where it holds up just a second, then it goes down to the QRS, and the QRS contraction is going towards the positive thing, right? It's going towards the positive pole. And then it gets to where it may briefly go back behind the ventricles to go get the other areas of the ventricles, and so it will briefly read negative. Because it's that brief moment whenever that electrical signal is going down then coming back up real quick to engage the whole ventricle. Alright? And so that's why it reads negative, because it's just going away from the positive pole. Y'all following me?
It's just got away from the positive pole in the ECG and the EKG.
Well, in the heart too.
Yeah.
In the heart too, yes.
So
Alright?
positive in the heart is
Yeah, when we're looking at lead 2. Not always. It depends on the lead that you're looking at. But for what we need to know right now, yes, for lead 2. Alright? And then, when the ventricles start relaxing and release that little bit of electrical stimulus, is still going to be traveling towards that positive. That's why you've got a positive waveform. Now, what's important to remember is when you get into arrhythmias, you may have arrhythmias that actually have a negative P wave or negative deflected P wave. Or you may have arrhythmias that have a very, very negative Q wave and then a positive R wave. Alright? And so that's going to get into some of your arrhythmias and things like that, but it's important to understand how a normal sinus rhythm would look going by lead 2. Alright? And that's what that is right there. Made sense? So your baseline represents your electrical silent period, or just a period when there's not an electrical charge. And so your wave that's printing out it should consist of your flat line and then your positive and your negative components on your biphasic. And so explaining this through using the biphasic leads is going to be the easiest way to understand it, because if it's a positive deflection, it's heading towards a positive pole. If it's a negative deflection, it has taken a moment, went away from the positive pole, and then it's going back down. All right. Your ECG paper. If you look on page 945, 944 and 945, your ECG paper, and I'm bringing the monitors up here in just a little while, but your ECG paper, it consists of small and large boxes. All right, y'all see that? Look at the pink paper on 945. You've got the big dark line pink boxes, then you've got the tiny boxes in the middle. So each one of those tiny boxes represents 0.04 seconds. One large box has 5 of the 0.04 second boxes in it. So one large box is going to equal 0.20 seconds. Then your vertical axis is going to represent the amplitude. So your amplitude is going to be the intensity in which the cardiac muscle is contracting. All right. So if you've got a QRS that's real big, then the amplitude's higher, as opposed to someone whose QRS isn't contracting as hard, and their amplitude may be a little bit smaller. Does that make sense? And that all has to do with contractility and the contraction of the heart and the ability of the electrical system to actually make that part of the heart contract.
I thought that we were supposed to be able to access our doors online. Do you have to be like when whichever you learn this election? I could not find one on Facebook. Yeah. I couldn't find it.
Okay, well, we'll get it figured out.
Yeah, it just sounds like a link on my book.
Where's your hard copy book?
So the house, we have 2 other classes. And Rude,
Maybe you should get a bigger book back.
yeah.
So it's going to be important to know the timeline of the ECG paper, because certain waveforms, they're only supposed to last a certain amount of time. All right? So when we look at a monitor, when we look at a strip, we need to have at least a 6-second strip. All right? At least a 6-second strip. 6-second strip. 6-second strip. I heard you mimicking me. If you don't have a 6-second strip, it's going to be harder to count, all right? Because what we're looking at is, if we're counting in 60 seconds. So if we've got a 6-second strip, we can count the QRS complexes and multiply that by 10, and that'll roughly give us a heart rate, all right? So how many big boxes is going to make up 1 second? 5. 5. So how many 5-box sections should we have to make up 3 seconds? All right. So you actually need 30 sections. Yeah, to make up 6 seconds. All right. It'll make a little bit more sense when I actually hand you your piece of strip paper. So this is going back to your phases and all that. We talked about this in detail the other day and all, but the your phases, it represents what? What does this represent? Phase 0, 1, 2, and 3, and 4. Cardiac depolarization, right? sodium potassium pump, rapid influx of sodium, rapid or influx of calcium, and all that, right? And so each one represents the area on the QRS. So it makes sense right here that the rapid influx of sodium, where it gets its highest electrical charge, is actually going to be on the Q wave, right? Because that's where your highest amplitude is. That's where your hardest contraction is. So that's where it's got to become the most positive.
What is the PR wave?
There's not a PR wave.
PR interval.
It's the PR interval. It's the interval between the start of the P wave to the R wave, or the QRS complex. All right. I've got just a few slides and we'll take a break. Are y'all good for right now? All right, your P wave. Smooth, round, upright. This is what we're looking for. Amplitude of less than 2.5, normal duration of less than 100 milliseconds. Or a normal duration of less than 0.20. One large box.
There's just a little bit. That's at 100 versus 110.
Yeah. Your PRI includes atrial depolarization and the conduction of the impulse through the AV junction. All right? So it's going to be your PRI, and this is important because this is going to be part of your interpretation. It's going to be the very start of the P wave to the start of the Q wave. All right? It's going to be the start of atrial depolarization following the conduction all the way down the internodal pathways to the AV node. Okay? It's a normal duration of 0.12 to 0.20. Alright? Write that down, underline it. It's going to be important in just a little bit. The QRS is your three waveforms representing depolarization of your two contracting ventricles, your Q, R, and the S. Alright? Less than 120 milliseconds, but it should be .12 seconds. Alright? 0.12 seconds. That's the numbers you need to know these. 0.20, 0.12, things like that. The good QRS is going to show that things have depolarized smoothly. So your QRS is going to be comprised of your Q wave, which is your first negative deflection. It should not be very. It should not be a very strong inflection. All right. Then you've got your R wave, which is where we're going to be actually. That's what we're going to be measuring heart rate off of if it's a regular rhythm. All right. And then your S. And your S goes back until it gets to your T wave, to your baseline till it gets to your T wave. Then you've got your ST segment right there. All right? The J point is where the QRS complex ends and the ST segment begins. So if the S wave just returns to baseline, it's going to be at the little area right there. If it goes down to a little bit of a negative, then comes up, it's going to be right there where it hits back on the isoelectric line. All right? So your J point is going to be wherever your S wave ends on the isoelectric line and wherever your T wave begins at that connection. Okay? That's your J point. Does that make sense?
So in the case of this deelevation, you have a difference.
Yeah, you would. It would just. Yeah, it would be easier for me to show you if it was. So let's just pretend like this is the S wave here, so you may have ST elevation. Forget about this right here, this is it. ST elevation, so your J point's still going to be where your S ends and your T begins. It's just that it's...
Even though it doesn't get back to baseline.
Yeah, it's just that it's atypical. It doesn't get back to baseline, but it's still going to be, your J point's always going to be where your S ends and your T begins. So then your T wave is ventricular repolarization or ventricular relaxation. The first half represents the absolute refractory period. Then the second half represents the relative refractory period. So this first half right here is going to be your absolute. Nothing can occur on that, right? Nothing can stimulate that. But your second half, this is your relative, all right? So this is what I meant the other day when I talked about R on T phenomenon. If the heart, if these cells are stimulated again, they could have a quick atrial all the way down to ventricular contraction. They could actually overlap right here. So if that heart stimulated again, it could, or it could even have a ventricular contraction without a normal atrial contraction. And so you may actually get a Q wave, which it doesn't look like that, but I'm just showing you, a QRS complex, and your R wave is actually starting to fire as your ventricles are trying to relax. So basically what it's doing is it's catching them at a real vulnerable point, and it's trying to send that electrical stimulus to them while they're trying to relax, and it's just going to cause all kinds of excitation and be a potentially deadly rhythm. It would go into something like a VFib or a VTAC or something like that. You wouldn't really see it. Only way that you would see it would be maybe shortening QT intervals, the area from here to here, and then you might start seeing some waves start to overlap on top of it, and then eventually it goes into VFib or VTAC. Your QT interval, which is what I just talked about, represents all the electrical activity of the ventricular cycle. All right? We'll get to dysrhythmias in a little bit. All right.